We will be discussing very briefly this trial, Bevacizumab plus erlotinib versus erlotinib alone in Japanese patients with advanced metastatic EGFR mutation positive non-small cell lung cancer, NEJ 026, overall survival analysis of an open label. We all know this, the timeline of the drugs discovery, the different response rate, PFS and OS of different TKI, first, second, third generation, and osimertinib is the first line recommendation and other drugs. Now the update, this trial was initially published in JCO in 2018. And we see that the trial schema is like that. Those patients who were treatment naive EGFR mutation positive, they were randomized to Bev plus erlotinib versus erlotinib, and this treatment was continued till progression, and further on progression, platinum pemetrexed based chemotherapy plus minus Bev was continued. So this trial was well balanced as compared to exon 19 or L858R mutation, and we see that the PFS, there was PFS improvement in the entire subset of patients with erlotinib plus Bev having a PFS of 16.9 months versus 13.3 months with a hazard ratio of 0.6. This forest plot shows that the benefit was maintained, well maintained in the entire subset of patient, even in L858R mutation, it was the PFS was maintained. If we go by the exon 19 versus L858R, it's 16.6 versus 12 months. It's far numerically more in the exon 21 mutation. It's 17.4 versus 13.7 months, with a significant p-value and a hazard ratio of 0.5. So around partial response, it was around 65% versus 63% patients in each of these arms, and the depth of response was also better in the combination arm. But this PFS benefit, depth of response came at the rate of higher toxicity, grade 1, grade 2, either it is pulmonary hemorrhage, proteinuria, non-pulmonary hemorrhage, hypertension. So it was toxic. Now coming to the updated analysis which was published in January, the overall survival, numerically better 15.7 months versus 46.2 months. The hazard ratio is around 1, so it was non-significant. Quality of life improvement, definitely there were 2 months improvement. Initially it occurred 2 months earlier. So to conclude, even in subset of EGFR mutated patient, there is an unmet need for further treatment plan or treatment design apart from the EGFR drug. So this trial, despite the PFS benefit, this trial didn't show significant OS benefit, and the probable reasons for this might be second line of treatment. And what I learned from this trial, that I think Bevacizumab we have now saturated. Apart from colon and ovarian cancer, we should leave this drug 14 years down the line. We should think of second, third generation of Bevacizumab, just like second, third generation of the other drugs. Then we could have some good result. But if you have to plan some trial in the lung cancer, further randomized trial like combination of first generation TKI along with chemotherapy plus minus Bevacizumab may be planned in L858R subset, especially in financial constraint situation like ours, where osimertinib is still not, we can't use in all our patients. So I think in a very subset of patients, further trial designs might give the answer. Any query, any questions? So this trial doesn't have the results that will take your post-lunch drowsiness. The results are not so. You won't get the kick, but still we can think of how to use Bevacizumab in further. Thank you.